I think in the interest of time, we might actually start. I will stop sharing and I hope everybody can hear me okay. If you can't, holler or something like that. So just to say good morning or good afternoon to everybody. Welcome to this webinar. We're absolutely delighted to see you all here. My name is Vanessa Moore. I'm the Scientific Project Manager of DRNI. The DRNI Hot Topics in Dementia webinar series is an ongoing project. And in the past, we've covered topics such as dance and dementia, sex and gender differences in dementia, vascular dementia, Parkinson's disease, and so on. All of our previous webinars are available on our YouTube page, so you can go there and look if you'd like. This one will be up there as well once we've finished editing everything. So in the next few days, hopefully it'll be up. So I'm absolutely thrilled to be able to introduce today's topic, which is the economics of dementia and brain health. And to bring us through all things health economics, I'll introduce our speakers for today, which are Dominic Trépel, Daniel Araya, and Meng Hoang. Dominic Trépel is an assistant professor of economics at Trinity and the Global Brain Institute, GBHI. He's the director of the Trépel Lab in the Trinity College Institute of Neuroscience, or TCNI. And most importantly, Dominic is also a member of the DRNI Management Committee. Our second speaker is Daniel Araya. He's a PhD student at Trinity College, Dublin, where his research focuses on how individual preferences for health-related behaviour impacts brain health. I hope I got that right. And Daniel will speak to us today about choice experiments as a method to elicit individual preference for health-related choices in the context of dementia. And then our third speaker is Meng Hoang. She's a PhD student in Trinity College also, where her research is in economic evaluation of interventions on dementia. And Meng will talk to us today about economic evaluations, again, in the context of dementia and brain health. So just before I hand over to Dominic, just ask you to keep your mics muted if you can. And also there's a Q&A button down at the bottom of your screen. So we should have time at the end for Q&A. So please, if you have any thoughts or questions that pop into your head at any stage, feel free to throw them in there and we'll be delighted to answer them at the end. So over to you, Dominic. Thanks so much.
Great, thank you. Thank you, Vanessa, such a lovely introduction. So welcome everyone today. It really is a pleasure to be welcoming you all to this session that we're putting on today. Just to give you a little bit of orientation to how we're going to spend the time together. Really what we've tried to do for today is to give you, an introduction to what we're doing as researchers to support the economics of dementia and brain health. So we're going to keep it quite top level, but what we're going to be working towards at the second half is to have some breakout rooms, which will give you an opportunity to select where you'd like to go. So you'll hear from Daniel and Meng in a minute, and they'll tell you about their particular interests. And what we're really interested to do is to, as part of the DRNI network, is to use this like a bit like the second half, like a clinic structure. So you can come in, talk about your research ideas. So really, this first half is just for us to kind of whet your appetite, tell you a bit about our field of research, and then the second half will give you the opportunities to really kind of explore, and you'll have the options to select into different breakout rooms at that stage. So you might even want to circulate between two of them if you wanted to kind of get a taste of both. Great. Okay, so what I'm going to tell you about is the economics of brain health and dementia, which is something that I've been working on for about 15 years now, and Daniel and Meng are joining this plight with us and conducting research for their PhDs. Okay, so let me just start off with a statement. So I want you to all, before we go into any detail, think about what makes you value your brain, okay? And really, like, I want you to be thinking about this throughout the course of this, because something that we don't stop to do quite very often is to think about how we assign value to our brain. Okay, so do be thinking about that as we progress. Okay, so before we go into any detail, because this may be for some people the very first time they've heard about health economics, I want to start off with some very simple concepts. So firstly, it's a question of what is health? And that is a super easy question for a lot, but just to help you understand where we pin this to, we start from a kind of textbook definition put out by the WHO in 1948, just following the Second World War, where they defined health as a a state of complete physical, mental, and social well-being, and not just merely the absence of disease or infirmity. So it's a nice broad definition that I hope we can all relate to. So the second thing is, because we're going to be talking about brain health, we need a definition for this. So again, WHO much more recently, and this is very much an emerging definition. I don't think anyone's completely agreed a consensus on this, but currently WHO have stated that brain health is a state in which every individual can realize their own abilities and optimize their cognition, emotion, psychological and behavioral functioning to cope with life situations. So it kind of, again, tries to encompass what our brain is giving us. Okay, so hopefully that applies both to brain health and also that subpart of dementia. Okay, so on the other side of the equation, maybe sometimes I would stop and if we were in person, get you to raise hands, but some people have learned economics, others haven't. So let's just give you a very brief introduction to what is economics. So if you were to meet my children, they would tell you, you would realize very quickly that they have unlimited wants. And poor me, they don't realize that I have only limited resources. So economics is quite a useful set of skills, which is about making choices between what we want and what the budget means we can afford. And I think you'll hear from Daniel and Men two very different approaches to thinking about that today. And it just will help you to illustrate some of the kind of methods we take to helping high-level decision makers think about this. Okay, so economics is not a new concept. Economics applied to healthcare maybe is a little bit more nuanced, but we all know like what a marketplace is. Like we're quite used to going to the supermarket, to hardware stores and choosing things that we want. And we generally think about, what it is. So here we have an example of someone looking for a TV, and they kind of know that it's going to be about this, 42 inches, it's going to cost, my budget is a certain amount. I want it to have, a variety of attributes. And that's kind of what drives our decision. And that's quite a normal marketplace. We kind of all know what happens there. However, when it comes to health, it's slightly different. So the market for healthcare is something to do with patients and caregivers who would be kind of our consumers, and service providers who would kind of be our producers. Okay, so that's already a slightly different description to what we've seen with buying TVs. So on the patient side, there's unpredictability. So health is a critical good that we have an unpredictable demand for. So we don't know when we're going to need health. We usually have it till we realize that we don't, and then we really want it. Okay, so it's unpredictable. And on the service side, these aren't physical goods that we're talking about. They are services a lot of the time. That we go to hospitals, we go to see doctors. So it's not something that we buy off a shelf, right? So as economists, we've defined this slightly differently. So one of the attributes of that is that we can't test our products. We don't know what, if, going to see this oncologist is going to be good oncology. We have to just, we have to just trust the system to do that. Okay. So, sorry, wrong button. It's further complicated that we don't really have agency over how our money is spent. We have to entrust our money most of the time, not always, to a third-party payer. And that could be the government, that could be our health insurers, or that could be other kinds of entities that you get in places like the States. In some lower resource settings, people do pay out of pocket, but there's loads of issues that come from that. So we've got this really odd market that comes from that. And there's a lot of issues that when we think as economists about this, that happen. And so this started 60 years ago with a guy called Kenneth Arrow, who got us thinking that there's a specialized market for health. And one of the things he talked about is there's specific market failures because of these weird things that are going on in this market compared to when we buy a TV. And one of the main things that was proposed is because there's lots of unevenness in the information in these three parties, the solutions are often to improve the amount of information. Okay, so that's all you need to know about health economics. But if you know that, you're doing really well. Okay, so here's a textbook definition of economics. It's basically it's the study of how people and organization make use of scarce resources that have alternative uses and the rewards that they get from those. Okay, so the real focus is towards scarcity. So when we apply that to health, we think in terms of the quantity and quality of life. So I've said brain health instead of health. So our final question is to think about the economics of brain health, which is what all three of us that are speaking today are researching. And this is a study about how people and organizations use scarce resources and the rewards achieved in terms of brain health. And we had a definition of that, which is the quantity and quality of the abilities, cognition, emotion, psychological and behavioral functioning. Okay, so that's really broad, but in many respects, with the economics of brain health, I'm trying to set out a field of work for the future. So it's very broad and encompassing. Okay, so to give you a little bit of a sense about this, firstly, we think a lot about dementia. For any of those that are here today, you've also probably been thinking about dementia yourselves. We know that the market has kind of changed towards thinking about things that we can do early on in life. And this is part of the Lancet Commission research that looked at modifiable risk factors throughout the life course. And this really started to shift what we think about in terms of dementia throughout, giving it a more of a life course view. That's why I put dementia within brain health on this agenda. Okay, so just to give you a little bit of an insight to some of our research, here's a piece of work that Dr. Sanjit Sahar and I and colleagues in Lund have produced, which has shown that there is strong cost basis for applying this hypothesis. In that, firstly, what we see here, if you see on the axis, we see both men and women compared, and we see at time zero is the point when people receive their diagnosis of dementia. And you can see on the vertical axis, the amount of costs that the system incurs, right? So we can see that, of course, at diagnosis, there's a huge spike in the costs of diagnosis, and that endures for the years afterwards. However, it kind of challenges the hypothesis that we've got these high costs forever, because particularly when you look at women, we can see actually their costs start to drop down. So below what people without dementia would have after 4 or 5 years, which really starts to make us think about equity concerns in dementia. And I think for those of you who've been thinking about dementia, you probably see this in practical settings, that a lot of attention, and then maybe people start to not receive as much care as they might have done. The other part that speaks to the brain health hypothesis is what's happening before. So before diagnosis, we were able with the Swedish data to look at people 10 years before. That's because they've got fantastic registries of dementia patients in Sweden. And you can then link those people to their health records and then look what happened. The fascinating thing that comes out from this is that people who are going to be diagnosed with dementia in 10 years, you can already see changes in their healthcare costs 10 years before, which really points to the fact that something is going on with these people. And that something suggests that it's something that we can alter. Okay, so some really interesting research there, just to give you a taster of what we're thinking about. Another piece of work we're doing is really thinking about what has the world done in terms of economic evaluations, and Men and Sanjeep are helping out this work. And what we've done is we've documented around the world who is doing economic research in dementia, so producing economic evaluations. And you can see here the countries that stand out. So obviously the dominant countries that the biggest pizzas of the pie are the UK and the States. And then we can see small slivers. But what we don't see is a lot from Ireland here. Okay, so hopefully this is a call to action for everyone here today, to kind of, as you're planning your research, to incorporate in things that not only are good research, but also help people to better policy decisions about allocations of resources by speaking to one of us three in the future. Okay, this is just a further elaboration of what we just seen, but this is essentially country by country, the production of economic evaluations over the last 20 years. So again, the take-home message is we don't get enough attention in this space. I mean, if you were working in cancer research, you'd see loads. Like this would be like too busy to even focus in on the maps. Whereas we can see just a scattering of things around the world in this. And really, in my role with the Global Brain Health Institute, one of the things I'm driving forward with all of our fellows is to try and change this. So everyone is encouraged to study health economics and to consider, using economics in their future research, if that's what they're doing. Okay, so I'm almost finished. I just want to start just saying why we do this. So one of the things is about efficiency. So a lot of people like to occupy this flat of the curve where they're not getting much more benefit for what they pay. But that means that there's a lot of wastage going on. Dementia is more like point A, which is, we're probably underspending at the moment and we're not realizing a lot of benefits. And what we all need to do by production of economic evidence is shift people to point B, which is where the flat of the curve starts to occur. That's the most efficient point. And a good example for that is in dementia research. So when we look at the burden of different diseases, so for every £10 that was spent, this is a UK study, cancer receives a ratio of £1 8 pence towards every 10% of the burden. Whereas for us in dementia, it has been documented as being 0.08 pence, essentially. So we're really behind. So again, hopefully you'll take away from this that by using economics, we're able to encourage people to allocate more resources, both to services and also to research. Okay, so just to introduce the people you're going to hear from in a second, to the left, we have Hoang, and to the right, we have Daniel Araya, and they are both working with me at the moment on a GBHI funded project called the Economics of Brain Health, which is a 3-year funded study, and which aims to create state-of-the-art decision analytic models to compare a range of potential alternative investments to prevent, treat, and care for dementia. So really, you've got experts joining you today. These are the future leaders in this space. Okay. What Men is going to be talking to you about is really about cost effectiveness analysis. And this equation here tells you about our smoke. We don't go into the maths of this, but essentially what this says to policymakers about the value for money of whatever you're thinking about doing. And I don't mean just drug therapies. It could be music interventions. It can be dementia registries. It could be whatever. And it's really to say, this is why it represents value for money, and this is why we want to continue it in the future. On the other side, we're going to hear from Daniel, who's going to tell us about methods to understand why people make choices. So as we're going to this world where we're trying to encourage people to make changes throughout their life course, how people make their choices is vastly important. We know how we make our choices when we go to the shop. Do we know how we make our choices when it comes to improving the quality of our brain? How much does it motivate us? So I'm going to hand over to them now. Firstly, I'm going to hand over to Men, who's going to spend about 5 minutes giving you a taster on economic evaluation. Then we're going to hand over to Daniel, and then I'll come back in and we will then be giving you the opportunity to join small group discussions. So that's it from me for the moment, and I'll hand over to Men. Before we go any further, while Men's pulling up slides, are there any points of clarification, not necessarily major questions at this stage?
Can I just say, I understand this is going to be on YouTube later?
Mm-hmm.
Okay, good, because I can't keep up quickly enough with the notes.
Okay, sorry. Yeah, we're trying to cover a lot of ground, and you have a chance to clarify in the room if there's anything that I've speeded over too quickly. Thanks for that. Okay, over to you, Men.
Can I share my screen?
Please.
Sorry, there's a technical problems on my laptop. Oh. Can you see my slides?
Yeah, they're up now.
Yeah.
Yeah, okay. So welcome to my sessions. I want to introduce a little bit about myself first. My name is Men, and I'm a PhD student at Trinity College Dublin. During my PhD program, I've been working on the model-based economic evaluations project for intervention for dementia project. And today I want to talk briefly about the rationale of economic evaluation in healthcare. Yeah. So next, I want to show you here a graph about the life expectancy of women aged 65. As you can see that the life expectancy of women at 65 grew over the past 3 decades. And according to the updated to 2020, an Irish woman aged 65 expected to live more than 21.9 years. And here also for the life expectancy of men at 65, he is expected to live more than 90 years. And so it means that the life expectancy of elderly is increasingly. Yeah, that's really good news. But there's also the bad news. As you can see here, the healthcare spending also has been increasing in the past 30 years. And we can clearly see an increasing trend of OECD countries, and the average house spending for an Irish reached to more than 5,000 USD in 2020. And other bad news is, as Dominic mentions about that, the resources are limited, and so is healthcare resources. And we can only spend money once. It means that you cannot have a cake and eat it too. So in economics, it's called opportunity cost. And in healthcare, money spent on interventions or treatment aid cannot be spent on intervention B. So the question is, which treatment should be chosen, and why should we adopt that treatment? So next, I'm gonna show you an overview of dementia. Dementia is progressive syndrome, and which means that the symptom of dementia will gradually get worse, and people may have early signs and symptoms 5 years before the onset of dementia. And according to WHO, an estimated more than 55 million people are living with dementia, and about 10 million cases are reported annually across the world. And as you see in previous slides, demographic shift shows an aging society and increasing life expectancy of 65. So the number of people will be living with dementia is expected to rise to around more than 131 million by 2050. And associated cost of dementia is projected to reach about 2.8 trillion US dollars by 2030, and the care provided by informal carers is attributed to 50% of these care costs. Yeah, and because the resource and budget constraint, resources for dementia must be utilized in the most efficient way. And the economic evaluation of health interventions provide a framework to conduct comparative analysis of alternative course of actions in terms of their cost and effects. So economic evaluation is a useful tool for financing and providing health services such as prevention, screening, diagnosis, strategies, treatment, and care available for people affected by dementia. And in economic evaluation, costs are measured in monetary units, while the effects of or consequences of treatment can be measured in health years or quality adjusted life years. And there are two study designs of economic evaluation. The first is trial-based economic evaluation. This type is conducted along with it is commonly conducted along with the randomized clinical trials. While the model-based economics evaluation, the idea is we will develop a model structure and we extract data from multiple clinical trials or other source of data, and then we combine them and compare between intervention to decide which is the optimal intervention that we should adopt. Yeah, and due to the limited time, just 5 minutes, I hope my presentation can briefly introduce you about economic evaluation in general and in that apply for interventions for dementia. And if you would like to know more about the model-based economic evaluation of interventions for dementia, feel free to contact me. Yeah, thank you for your listening.
Great. Thank you. So you'll have, after Daniel's talk, you'll have an opportunity to pop in and speak to men in the breakout room. And if you're thinking about doing a trial or you need a model to be developed to show some value of what you're thinking about proposing, you'll have an opportunity to sound out those ideas then. Great. So I'm going to hand over now to Daniel, who's going to tell us a bit about choice experiment methodologies. Thank you.
Hello, everyone. Please, Daniel, can you see the slides right now? Yes?
Yep, they're coming up perfect.
Perfect, great. First, thank you for joining this webinar. As Dominic already and Vanessa presented me, I'm Daniel Araya, and I'm doing the PhD in Economics of Brain Health with Dominic. First, before starting going into discrete choice experiments as a method to elicit people's preferences, I think it's useful to first make a little distinction between microeconomics and macroeconomics. Usually economics can be, I think, those two groups. Microeconomics, by one hand, focus on how individuals make choices. In the first stages of economics was like how many of any products I want to buy. And by the other hand, macroeconomics focus on how all the decisions of multiple individuals create macroeconomics, like for example, usually exchange rate, inflation, all the stuff. And these specific methods are more focused on microeconomics. So what we try to do is to understand how individuals choose between different options. So what we usually have, when people already know that, for example, they want to buy a shirt of one specific color or design, how people process the information of those two options to finally choose which one they want to buy. For example, in the case of a shirt, we could have like option A or B. In those, we could have like different colors of shirts, different materials, length, design, and price. So these type of methods have been used a lot in market research to try to estimate and understand the importance of all these characteristics on people's decisions. So at some point, people start to realize, okay, this is really useful to other questions, really important questions that are not related to market research. For example, if we go one step further into health, let's suppose that people have to choose between different cigarette packages. They already know they are smoking, but now they have to choose between which cigarette package they want to smoke. This is from a study I did in Chile that we were trying to estimate the importance of the package in smoking. For example, here, if you see the option A has the plain package that is here in Ireland, and option B, you have the design package that we still have in Chile. And we also have a little warning in the stick saying that smoking causes cancer. So what we wanted to do here is to get an estimate on how important is the package, the plain package, in the decision of smoking. For smokers choosing that package, and for non-smokers, how that attribute, the characteristic of the plain package, can impact the decision on non-smoker to start smoking. So this is a method with the last objective to measure and understand how, if we change one attribute or characteristic of a specific product, change the decision of smoking or smoking, or doing other behaviors like doing physical activity, food, healthy food versus junk food, etc., etc. And then we can go a little bit further to get closer to more dementia-related choices. This is a specific type of discrete choice experiments or time trade-off, where you ask people to choose between two types of, let's say, like life states. For example, they can choose between state A, where they feel extremely anxious or depressed, against life state B, where they're not anxious or depressed. So you see that they have to choose between how they will live some certain amount of years with this characteristic on their life state. For example, usually the best the conditions are, the less you live, because you want to try to get some sort of trade-off. For example, here, the best state only lasts for 4 years and the worst lasts for 10 years. So what you have to choose is, okay, do I want to live more in maybe a not so well like state of health, or you are willing to exchange some life years to live in a better health state in 4 years. And this is another option, like trying to get more closer to dementia related questions. This is a specific method called AD5D that's it's used to measure people preferences for health characteristics related to dementia. Here, for example, they use in the same structure. We have two options. People have to choose between option A or B. In option A, they have poor physical health, good mood, fair memory, good living situation, and good ability to do things for fun, and they get to live in this situation for 4 years and they die. In contrast, in in option B, they have excellent physical health, fair mood, fair memory, good living situation, fair ability to do things for fun, and that lasts for 4 years. So the basic idea, in simple, is that we repeat these choices multiple times, changing each time we change the attributes. So we are trying to measure when people are willing to trade off between, for example, excellent cognition versus probably good physical health. So then we try to get a measure of importance on how all these different attributes rank for people, so they can make a choice between. It could be a treatment, it could be a prevention method, diagnosis of its use. In the case of diagnosis, usually the attributes are how efficient is the diagnostic, how expensive it is, the amount of information you get from the diagnosis, and usually the price. So to sum it up, the main idea of this discrete choice experiment is so we can rank how people rank all these attributes in order to choose a product, treatment, diagnose, or even a health state for their future life years. Thank you very much for listening.
Great. Thank you so much, Daniel. So that gives you a sneak preview into the ideas of eliciting what drives people's choices by presenting these kind of choice set type of experiments. Really has lots of broad applications. You know, we can think about it in all sorts of different contexts. So it's a really flexible methodological approach and definitely worth learning a little about. Okay, so again, we could probably take a moment to invite you to ask points of clarification before we open out the breakout rooms. But just to give you an idea of how the breakout rooms are going to run, they're going to give you essentially 10 minutes to kind of go in. I'm going to be floating between the two breakout rooms. You're going to have men in one of the rooms and Daniel in one of the other rooms. And it's really to give you an opportunity to kind of bring your research in, whatever you're thinking about doing, and discuss how might you look to augment what you might already be trying to do by adding either an economic evaluation or a choice experiment into this. So it's a structure that the reason I propose this today, it's a structure that when I was working in York in the UK, we did a lot of. It was essentially to bring together the research community with specialists in a specific area called the Research Design Service, and give you an opportunity to kind of have a few minutes with an expert and kind of explore an idea. So like I said, you'll see the breakout rooms open in a minute, and you'll get the opportunity to kind of go into one of those and have a chat. Okay, so those will be opening up now. And as you can see, you'll now see something popping up on your screen which says, choose between economic evaluation or choice experiment. Okay, so Daniel and Men will make their way into their respective rooms, and you can join as you wish. Okay, if there's any points of clarification, I'll be staying here for a few minutes and you can speak to me. Otherwise, I will float around between the rooms. Right, so usually the breakout rooms close just as you're getting into something. So hopefully that hasn't happened for too many people today. And hopefully you've all had a chance to kind of sound out some of your ideas. Certainly where I've been, I can see there's a few kind of potential points of collaboration. So if we come away with a couple of ideas in the day of things that, developing something, I think DR and I, as someone who sits on the management committee, we're kind of ticking the box of what we're meant to do, putting researchers in different walks of life together. So let's hold on to those ideas and take them forward. So we have about 6 minutes left if we're finishing on time for Q&A, and we've had a couple of questions come up in the chat. I'm going to take the second one first, which was, I'm not sure who it came from, but it was about equity concerns in economic evaluation. So, how do we think about, people who are in different social economic stratas when we're doing economic evaluation? And is it a really good point to make, because actually economic evaluation is all about trying to push forward efficiency in systems. But it's very well documented that when you try and improve efficiency, it can be at the expense of equity. So there's something that we refer to as an efficiency equity trade-off. So recently, people have tried to think about equity concerns by saying, instead of trying to improve efficiency for the average population, which might sometimes help certain cross-sections more, maybe the worried well can get the benefits over those. There's an approach to kind of think about targeted evaluations, to think about different disparity groups, so there are methods, but they're quite advanced methods. So let's just make a point on that, and I'm just conscious of time. And the other point was from Louise, which was to do with what we did in the national, when we did the analysis using the Swedish registry data, where we're controlling for different ages. So the data that I showed in there was very much the poster. And it's strange when you call a very, very dry graph a poster, but that's our academic world. But it tells a very interesting story. But the The Swedish collaborators did extensive kind of econometrics analysis, which controlled for all sorts of points of variance. So you can see lots more disaggregation if you look at the full paper. So that's just to address those two that came up in there. But I want to allow some, just a little bit of extra time for people that are here, just to either share reflections on today or any points of, you know, that are still playing on your mind that you'd like to raise. So are there any questions first and foremost that people feel are still playing on their mind they want to kind of bring in before? No. Okay, well, I'm interested to hear your reflections then. What are people's thoughts of today? Are there any things that you know you found useful? You know, anything that you feel like you're going to take away from today? Those types of things.
I just want to say thanks to Dominic and Daniel and Men, just really, really, really insightful presentation. It brought me back to my economics degree and my kind of choices I made for my PhD, particularly as Daniel was talking about, you know, the discrete choices, experiments. I suppose that's just my reflection, and you know, it also brought me on to thinking about just in regards to this type of kind of modeling for kind of upcoming disease modifying therapies. So like in the future when, well, hopefully not the too distant future, where people might have multiple options for treatment of Alzheimer's disease, you know, would this type of modeling and experimentation help them, I suppose, like rank their treatment options and the best choice for them? And I think that's something that I've never thought of until today. So thanks so much for that.
Great. Well, it's duly noted that you're a former economist working in the Alzheimer's Society of Ireland. So that makes you a health economist. So we're going to keep in touch with you from here going forward. And great points. Thank you for those. Any other reflections that people would like to share, or, you know, maybe bring back to the larger group about ideas that you're thinking about taking forward even? I think Leslie, you had an idea that you maybe you could share.
Yeah, and I don't have a degree in economics, so this is all very new to me. I work with St. John of God, and we provide support services for people with intellectual disability and mental health issues. But amongst the people we support with intellectual disability, we are aware that there's an increased risk of dementia, and as an organisation we want to prepare for that and look at what the demand is going to be for supports for people with intellectual disability who do develop dementia. What kind of resources do we need to have available so that we can continue to provide support to these individuals right through to the end of life? And how we capture that and cost it is something that I have no idea about, other than I know we can capture what our best practices and what we do. But to get your advice on how to even start getting the data so that we can cost it is really, really helpful. So thanks for the breakout room, and I will be following up and asking for help.
So exactly what we were saying, that's like what we're trying to achieve with this is to provide the kind of clinic structure where people can bring their ideas. We're hoping to be able to repeat these in the future. So if you've got other people that you come across you think can benefit, and just, you know, have that touch point and then develop their idea in the future. Yeah, perfect. So great example. Thanks, Leslie, for that.
Thank you. Thanks very much.
Sure. Anything else? Louise, you had some interesting discussion going.
Yes, I was chatting to Daniel just to see if the discrete choice experiments had ever been used with people with dementia, and you know, they haven't at the moment that, you know, that we're aware of in the current group. But we were thinking about things like the you know, the color could actually influence the decision, or the you know, there will be other aspects of the presentation or the content that could catch somebody's attention more than the content. But it then got me thinking about the fact that I'm sure we could actually develop a set that you know, and they could be around, you know, anything from sort of financial choices to health choices to care choices. So it's got me sort of thinking that it would be an interesting project to start to look at around trying to develop something visual, because that often that works better when you're chatting to people with dementia, but also validating them so that it is the content that is actually driving the decision. So yes, so lots to think about.
Great. Okay. Well, that brings us to time. Sorry, we're 1 minute over. So I just on behalf of Daniel, Men, and I just like to thank you all for coming today. And then I'll hand back to Vanessa to close.
Brilliant. Thanks so much, Dominic. Yeah, I just want to say just a massive thank you to yourself, Dominic, and to Men and to Daniel. You've been absolutely brilliant. So really, thanks so much. It was really interesting, and I really learned a lot as well. Just, you know, like I said, a bit like you, Leslie, I don't have a background in economics. It was all new to me. So it was really very, very interesting. And a huge thank you to you all for attending as well, and for your participation in the breakout rooms and everything. It's great to see an interest, you know, in this particular topic. And like Dominic said, we'll definitely revisit it more than once. So I really appreciate it. Just to say that, yeah, this will be up on the DRNI YouTube page. The editing usually takes a little bit of time, so maybe in the next couple of days it'll be up. But if you just go on to YouTube and search for DRNI, it'll come up. And yeah, just to say thank you again, and enjoy the rest of your day. It's lovely and sunny, so hopefully you'll all have a lovely day. Thanks so much, everybody. Thanks.
Thanks.
Thanks, everyone.
Bye.
Bye-bye.
Bye.
Bye.